Hello everyone, welcome to Raaonline. I'm Dr. Abinaya, I'm a consultant pediatrician. So in Nelson series, the next topic of discussion under the pediatric critical care and emergencies is ABG interpretation. So let's get started. So before going on to the interpreting our arterial blood gas, we should know the basics about acid-base balance and what is an acid, what is a base, what are the buffers which are present inside the system and how do they act. Okay, so this will be a very brief discussion and then we will go on with the sample ABGs and how to interpret. So what is an acid? Acid is any substance that releases H+. Alkali is a substance which will accept that H+. Okay, so this is the basic difference which we have studied right from our chemistry days, isn't it? So what is a buffer? Buffer is any substance which will weaken or attenuate a change in the pH inside the system. So when an acid or when a base is put inside the body, this buffer will immediately act so that the pH remains normal. It will try immediately to normalize it. There are many buffers inside the human system, some of which will act immediately, some of which will take time. It will take time 2 to 4 days to normalize it. So we will be seeing about what are these buffers in a moment. So the major buffers will be kidneys, lungs and intra and extracellular buffers. So why this pH has to be maintained normally? So normal pH between 7.3 to 7.4, this has 7.35 7.45 has to be maintained for all the biochemical functions inside the system. The H+ ions which are added in the system, they are highly reactive. They will immediately go and combine with the proteins and alter the functions immediately. So before going on to the little bit about the buffers, so the normal values we will take a look. So what is the normal pH? 7.35 to 7.45. So 7.4 we normally consider as the mid point of this normal range. PaO2. So in a ABG you will have these values. I mean there are many values in modern ABG machines where we will get electrolytes about the various other hemoglobins, methemoglobin, carboxyhemoglobin, etc. So we are not going to see about all those things. But the basic 5 to 6 values we will see. So number 1 is pH, which we have seen. Number 2 is PaO2. So normal PaO2 should be more than 80. PCO2 should be between 35 to 45. Normally we consider as 40, right? Next is bicarbonate. Bicarbonate, normally when you are interpreting the ABG or when you do the delta bicarb calculations, we take as 24. PCO2, the midpoint that is 40 is taken. So the bicarbonate normal range is between 22 to 26 millimeters mercury. Normal anion gap is between 12 to 16. Okay. So we will see how to calculate anion gap, etc. And base deficit or base excess is plus or minus 2. So these are the normal values that we all should be familiar with. So we will take a look about the buffers. So the physiological buffers are divided into two: bicarbonate and non-bicarbonate buffers. So bicarbonate is a very effective buffer because of the high concentration which is present inside the system. And bicarbonate and carbon dioxide, they exist in a close relationship. Okay. So carbon dioxide, just take a look at this equation over here. So carbon dioxide combines with water to form carbonic acid, which dissociates to give H+ and bicarbonate. So the enzyme that is responsible for this equation will be the carbonic anhydrase enzyme. Carbon dioxide, we all know it acts as an acid. So this carbon dioxide and bicarbonate will exist in a close relationship. This is an open system and this is one of the very effective buffers of the human system. So when there is, we talked about what are the buffers. First one we talked about lung, isn't it? Lungs will act immediately. Okay, whenever the blood carbon dioxide concentration increases, whenever there is an acidosis, lung will try to compensate immediately. It will try to excrete the carbon dioxide whenever the blood carbon dioxide concentration increases. We will now talk about the non-bicarbonate buffers. So these non-bicarbonate buffers are predominantly proteins, phosphate and bone. We will just talk about these three. Okay. So among the proteins, albumin is the predominant non-bicarbonate buffer. Among the intracellular proteins, hemoglobin is one of the effective buffers. Why proteins are effective buffers? Because of the presence of this amino acid which is histidine. So this histidine will have a side chain that will either bind to the H plus or it can release H plus and act as a buffer. Okay. So proteins are effective buffers. Next comes phosphate. So phosphate we know it can bind up to 3 hydrogen molecules. And bone is also an important buffer. So bone acts as a base. Okay, because of the presence of bicarbonate, that is calcium carbonate and soda bicarb. So bone acts as a base. Bone can dissolve, and when it dissolves it releases the base and it will buffer an acid load at the expense of its density. Okay, so the bone will dissolve and releases the base and acts as a buffer. So in the non-bicarbonate buffers, just remember these three: protein, phosphate and bones. Among proteins, albumin and hemoglobins are very effective buffers. Phosphate and bone are also effective non-bicarbonate buffers. So when it comes to lungs act immediately by excreting carbon dioxide whenever there is an excessive acid load inside the system. Kidneys will excrete the endogenous acid. We will come to it a little later. So normally children produce more acid load when compared to adults, right? So children produce around 2 to 3 milliequivalents per kg per day of H plus, which is more than the adults. And where from the acid load comes? One is children take a lot of protein. From the dietary protein metabolism, H plus comes. Next, from the incomplete metabolism of triglycerides and carbohydrates, there is an endogenous acid load. So triglycerides give rise to acetoacetic acid, beta hydroxybutyrate, and carbohydrate metabolism will generate lactic acid. Third, two loss of bicarbonate. Whenever each bicarbonate is lost, one H plus will be regained inside the system. So these are the three principal sources of H plus. Okay. So coming to the renal mechanism, there are two-step process. One is reabsorption of the bicarbonate, another one is secretion of H plus. So we have talked about this in detail in the nephrology chapter under RTA, isn't it? So we will see only the proximal tubular reabsorption of bicarbonate here, because most of the bicarbonate will be reabsorbed in the proximal tubule. Around 85% is reabsorbed in the proximal tubule. 15% is reabsorbed in the ascending limb of loop of Henle. So when all the bicarbonate reabsorption, normally it happens, bicarbonate reabsorption happens, 85% happens, but when there is a volume depleted state, we talked about the metabolic alkalosis. We have a presentation on metabolic acidosis and metabolic alkalosis, whereas we talked about this chloride responsive metabolic alkalosis, where it is a volume depleted state. Whenever there is a volume depletion state, the body will try to regain the bicarbonate. So it will try and reabsorb bicarbonate in the proximal tubule. So first, a volume depleted state is a stimuli for reabsorption. Next, hypokalemia. So it's just opposite for hyperkalemia. Whenever we have hyperkalemia, there is acidosis. When we have hypokalemia, there is metabolic alkalosis. Increased PCO2. Say in a situation, in a condition like respiratory acidosis, so which is increased PCO2, the kidney will try to conserve, reabsorb bicarbonate as a compensation for respiratory acidosis. Parathyroid hormone will decrease the resorption. So a high parathyroidism or hyperparathyroidism will have acidosis. Hypoparathyroidism will be associated with alkalosis. And acetazolamide is a carbonic anhydrase inhibitor. Again, that will impair bicarbonate reabsorption because it will inhibit this carbonic anhydrase enzyme. Okay. That was about reabsorption of bicarbonate. We just talked about what happens in the proximal tubule because maximum absorption takes place there. Next, come to secretion of H plus. So H plus is secreted. It is absorbed from the bloodstream through the sodium hydrogen ATPase, where H plus comes from the bloodstream into the proximal convoluted cell, whereas sodium is reabsorbed. So this H plus again through the same sodium hydrogen ATPase is secreted inside the lumen. So coming to the clinical assessment. So now you have a patient, you have done a ABG, you should know what kind of acid-base disturbance is present in that patient. So you have just come across what is a normal pH. 7.35 to 7.45 is normal. Acidemia means pH less than 7.35 is acidemia. Alkalemia means some pH more than 7.45 is alkalemia. We have patients who have not just a single acid-base disorder, but they can have two, metabolic acidosis plus respiratory alkalosis. So, it can be a combination also. A simple acid-base disorder means there is a single primary disturbance, like a diabetic ketoacidosis who is only having a metabolic acidosis. So, say they have only metabolic acidosis, then it is a single primary disturbance. Usually, we just talked about this also, respiratory compensation, that is lungs will try to excrete the carbon dioxide. So, lung will act as a buffer. It quickly compensates within the first 1 day, that is within the first 24 hours, whereas kidneys take around 2 to 4 days for the compensation, be it reabsorption of bicarbonate or the excretion of H+, it takes 2 to 4 days for the compensation. A mixed acid-base disorder means more than one primary disturbance will be present. So, we will talk about how do you interpret the ABG stepwise. So, before going on to interpretation, we have to see if the ABG that we have got, the ABG report is consistent or is it valid before interpreting it. So, for checking the consistency, we have this equation, Henderson-Hasselbalch equation. So, this equation, through this equation, we will have this H+ value, we will calculate the H+ value. So, in your ABG, you will have PCO2 value and bicarbonate. So, what you need to do is, you need to substitute. So, 24 into the PCO2 value of the patient, you substitute here, divide by the bicarbonate value of the patient. You will get a value of H+. So, you have to use this table to see if the pH and H+ are correlating to identify the consistency or to finalize if the ABG is consistent or not. So, you have done the equation and you have gotten an H+ value. So, you come to this table, say in case the H+ value of the what was calculated from the formula is 40, you correlate that pH should be 7.4. Now, you check the pH value in the patient's report. If it is 7.4, then it is correlating, then the ABG is consistent. You can move on to the next step of identifying what acid-base disturbance is there for the patient, right? So, step 1 is always checking the consistency of the ABG. So, this is present in all textbooks. This you can keep as a ready reckoner also. It is present in Harriet Lane, etc. Another method is, it is a crude method where you subtract the last 2 digits after the decimal point of the pH from 80. Okay. So, they say if you take the 7.35 is the patient's ABG. So, 80 minus 35. 45 will be the value, 80 minus 35, so 45 is the value. So, you check the approximate H+ in the report. If it is normal, then again the ABG is consistent. So, this is how you check the consistency of the ABG. Next, you move on to the step 2. Step 2 is identifying if it is acidosis or alkalosis. For this, you will take a look first at the pH. So, you know pH less than 7.35 or if it is more than 7.45. So, if it is less than 7.35, then you will write as acidosis, more than 7.45 it is alkalosis. So, step 2 is only this much, but also remember sometimes because of the compensation, pH can be normal. If the compensation is complete, it is a fully compensated condition, then your pH can be normal also, okay. So, keep that in the mind also. Next, move on to, now you have identified, okay, say, let's assume it is an acidosis. Now, you have to identify, is it a metabolic acidosis or is it a respiratory acidosis, okay. So, for metabolic, we look at bicarbonate. For a respiratory condition, we look at the carbon dioxide, okay. We will look at examples. So, you have seen that there is an acidosis. You look at bicarbonate. If the bicarbonate is low, it is a metabolic acidosis. If the PCO2 is high, then it is a respiratory acidosis. Simple. So, you have seen taken a look at the pH. pH is 7.3. Next, you will take a look at PCO2 and bicarbonate. If PCO2 is high in acidosis, it is respiratory acidosis. If bicarbonate is low in a condition of acidosis, it is metabolic acidosis. It is just the vice versa. In case, let's assume the pH is 7.49. It is an alkalotic state. You see, you take a look at the PCO2. If PCO2 is low, it is a respiratory alkalosis. If the bicarbonate is high, it is a metabolic alkalosis, okay. This you should remember. Again, this is presented in a tabular column. So, when you keep interpreting the ABGs, this is just a cakewalk. There is no problem so far. Okay, so everybody, I understand you would have all interpreted so many ABGs. So far this is very, very simple. Next comes the difficult part when you are interpreting the ABG, taking a look at the compensation, understanding if the ABG or if the child's condition, the acid-base disturbance is compensated or not. I believe this is the difficult part. So far, looking at the pH, PCO2, bicarbonate, you would have identified this is metabolic acidosis, this is respiratory alkalosis. So far, it is fine. Next, compensation. So, is it partially compensated or is it fully compensated? We will understand. Again, I am just putting this respiratory and metabolic compensation. So, just a recapitulating of whatever we have seen. So, respiratory compensation by the lungs is fast. It takes place in minutes to hours, whereas metabolic compensation takes place in days together. Okay. This slide you can have in your pocket notebook, or you can write it and keep when you are in an emergency setting or an ICU setting. So, this alone will be enough for you. There are lot of formulas to look for compensations, but this will be, I mean, although this looks very crude, but this comes in very handy. Okay, I have not dealt in detail about compensation, so this is like a quick interpretation of your ABG. So, we will understand what this slide is all about. Okay, so the first thing, so you have a ABG which shows metabolic acidosis. Okay, so for a metabolic acidosis, we understand the compensation has to come from the lungs. Okay, so there is a metabolic acidosis, which means bicarbonate is low. So, what has to happen? The lung has to excrete carbon dioxide. So, the carbon dioxide should fall, isn't it? Metabolic acidosis will be compensated by the lungs. So, the respiratory rate will become high. The carbon dioxide should fall. So, for every 1 bicarbonate low, 1.2 times carbon dioxide also should fall. Okay, so 1.2 times change of bicarbonate should be there. Simple. This is metabolic acidosis. Next, metabolic alkalosis. What happens in metabolic alkalosis? Metabolic alkalosis, bicarbonate will rise, will increase. If bicarbonate increases, what happens? The compensation again has to come from the respiratory side. So, the lung will hypoventilate. The carbon dioxide will be conserved. So, carbon dioxide will increase, right? So, for every 1 bicarbonate increase, 0.6 carbon dioxide will increase. Okay. So, this you will have to see. It is very easy for metabolic. See, this is metabolic acidosis, metabolic alkalosis. Look at the numbers here, 1.2 and 0.6. Okay. So, just remember these two numbers, it is fine. For metabolic acidosis and metabolic alkalosis, till this, just remember these two numbers, 1.2 and 0.6. Okay. So, here the beauty again is, for metabolic acidosis, what happens? I told you, bicarbonate will fall, carbon dioxide will fall. So, the movement of the bicarbonate and carbon dioxide towards the same direction. Understood? So, this compensation is metabolic. For metabolic condition, the compensation is easy. Come to the respiratory part. Respiratory acidosis or respiratory alkalosis is not quite easy. Again, it depends on the condition of the patient. Is it an acute situation or is it a chronic disorder that the patient is suffering from? So, we divide into acute and chronic. I want you to remember that just this column over here, this table over here, remember 1, 3, 2 and 4. Okay, so just put a table 1, 3, 2, 4. I will explain how. So, there is a respiratory acidosis patient. Respiratory acidosis means what happens? PCO2 is high. Okay, so if there is a respiratory acidosis, there should be a metabolic compensation. When there is high PCO2, what happens? The bicarbonate should increase. Okay, the metabolic compensation should happen. If it is an acute respiratory acidosis, for every 10 PCO2 rise, there will be 1 rise of bicarbonate, 1 change of bicarbonate. If it is a chronically respiratory acidosis patient like COPD, BPD patients, for every 10 rise in PCO2, there should be 3 rise in bicarbonate. Okay. So, this is for respiratory acidosis. Now, come to respiratory alkalosis. PCO2 is low. Bicarbonate should also fall. Okay. For every 10 PCO2 in an acute respiratory alkalosis, 2 change in bicarbonate should be there. If it is a chronic state, 4 change in bicarbonate should be there. Okay, so this is, I think, the most easiest slide. We have seen so many formulas. There is a Winter's formula for metabolic acidosis, which says 1.5 times bicarbonate plus 8 plus or minus 2. So there are many formulas for even alkalosis also. So I think this will be very easy. This slide, although it looks very just a crude method, but when you calculate, you will actually find that it is serving the purpose. So I want you to understand this slide, work out certain ABGs with this in mind. You will definitely get the right compensation. Okay, do not worry about it. And just remember these numbers. Okay, 1.2, 0.6, 1, 3, 2 and 4. Okay, so next is we have to see if there is a single disorder or a multiple metabolic disorders. For that, you will calculate the anion gap. Again, we have talked about anion gap in one another presentation. And for anion gap calculation, mostly we do not take potassium. So, sodium minus chloride minus bicarbonate is the formula. So, normally if potassium is omitted, the anion gap we take it as 12. Normal anion gap is taken as 12. So, if the anion gap is more than 15, we call it as a high anion gap metabolic acidosis. And if the anion gap is normal, that is 12 and less than 12, it is normal anion gap metabolic acidosis. Okay. So, what is this anion gap? I am not going to explain because we have already seen in another presentation. So, I just want to tell that there is one concept called as a corrected anion gap. So, if you know that the child is a hypoalbuminemic child, there is albumin is also less, then we have to correct the anion gap because albumin contributes to the anion gap. If the albumin is low, for every 1 gram low, you have to reduce the anion gap also by 2.5. Okay. So, that is very, very important. So, this is the corrected anion gap. So, let's talk about delta anion gap and let's talk about delta ratio. Okay. So, why delta ratio is important? There can be, not just one acidosis. Okay. Usually, we get this high anion gap metabolic acidosis, but sometimes there is a hidden normal anion gap acidosis and there can be a hidden alkalosis also, metabolic alkalosis also. So, whenever you have a patient of high anion gap metabolic acidosis, calculate the delta ratio. Delta ratio is nothing but delta anion gap by delta bicarbonate. We know normal anion gap is 12. Okay, so anion gap of the patient minus 12 is delta anion gap. Delta bicarbonate is normal is 24. Bicarbonate we take as normal as 24 minus bicarbonate of the patient will give you the delta bicarb. Delta ratio is nothing but you divide the delta anion gap by delta bicarbonate. So, depending upon the result, okay, the delta ratio is delta anion gap by delta bicarbonate. Again, this table is very, very important. Okay, so the delta ratio, if it is between 0.8 to 2, normally it should be 1. Okay, ideally it should be 1, but sometimes it is up to 1.4, 1.5. So, in such cases, if it is between 0.8 to 2, it is a pure high anion gap metabolic acidosis condition. There is no other hidden disorders. In case it is less than 0.4, it is a normal anion gap metabolic acidosis. Of course, this we do not want to calculate. We know just by the looking at the anion gap, if it is 11, 12, then you can just label as normal anion gap metabolic acidosis. The problem comes here. If there is a delta ratio between 0.4 to 0.8, it means it is a mixed metabolic acidosis. Both normal anion gap and high anion gap metabolic acidosis exist together. They coexist. In case if it is a more than, the delta ratio is more than 2, we have a hidden metabolic alkalosis. Okay. So, it is not just high anion gap metabolic acidosis, but there is a metabolic alkalosis which is correlating. Again, this slide is important. Okay. So, the compensation slide is very important. Again, this slide will serve you the purpose of when you calculate the delta ratio. Very, very simple formula only. Okay. So, I have talked about mixed acid base disturbances. Do they exist in real life? Yes, yes, they definitely exist. Okay. So, we will see some conditions where these two will coexist, where two conditions will coexist in pediatric patients. So, metabolic acidosis with respiratory alkalosis. So, this can be seen in sepsis. Sepsis can cause metabolic acidosis and then a hyperventilating child, there can be alkalosis. Renal failure corresponds to metabolic acidosis along with the pneumonia-like picture or a CCF can cause a metabolic acidosis with respiratory alkalosis. Metabolic acidosis with metabolic alkalosis. Say a diabetic ketoacidosis child with recurrent persistent vomiting will have this picture. Respiratory acidosis with metabolic alkalosis. This should be BPD. BPD child or a chronic lung disease. CLD child with diuretic therapy, on diuretic therapy will have this kind of a picture. Respiratory acidosis with metabolic acidosis, again most commonly seen in sepsis with MODS and intoxications or a cardiac arrest child. Okay. So, these are some of real life examples. Okay. So, we have these mixed disorders, but which came first? Which was the condition which came first? So, that we need to understand, isn't it? So, again it is a very simple formula only. So, for example, you have a pH, you have a ABG report which says pH is 7.25. So, it is less than 7.35, which means it is acidosis. Okay. So, now you look at bicarbonate and PCO2. Bicarbonate is 16, so it can be metabolic acidosis. PCO2 is high, that is 60, so it can be respiratory acidosis. So, I have a confusion. So, which came first? For that, we need to see the difference of PaCO2 percentage and bicarbonate difference percentage. Okay. So, PCO2 normally, this is normal, right? So, what is the patient's PCO2? It is 60. So, 60 minus 40 by the normal, by 40. Okay. So, this is 0.5 or 50% difference. Bicarbonate difference is normal bicarbonate is 24, whereas the patient's is only 16 divided by 24. So, this came around 0.33 or 33%. So, which has the greater percentage? 50% of course, isn't it? So, respiratory acidosis is the dominant disorder in this patient. So, this is how you calculate when you have a similar, like both acidosis is present and you have a doubt which came first, then you have to calculate in this way. So, before going on to interpreting our ABGs, what is the indication? Why do you do ABG? Of course, there are a lot of conditions. Okay. So, when you suspect an acid-base disturbance and when the patient is ventilated, to look at oxygenation and ventilation you do. To assess response to treatment, of course, in cases like in children with DKA, to assess the response, is the acidosis or is the anion gap closing, is the acidosis coming to normal. So, assessing response to treatment in conditions like when you suspect methemoglobinemia, carboxyhemoglobin, ABG has to be done. Okay, right. So, we will come to the scenario 1. So, I want you to look at this table first and then we will go on to the interpretation. Okay. So, pH is 7.34. Is it acidotic or alkalotic? This is an acidotic pH. Okay. Look at PO2, 85. What is a normal PO2? More than 80 is normal. Okay. So, it is normal. There is no hypoxemia. Next, come and take a look at PCO2. So, PCO2 is 35. So, PCO2 normally 35 to 45. So, this is, we can keep this as a borderline low PCO2. Okay. Look at bicarbonate. Bicarbonate is 18. It is definitely less. 22 to 26 is normal. It is definitely less. Okay. Then base deficit of 6.2 is present. So, here you have an acidotic pH. You have taken a look at PCO2. It is definitely not because of respiratory acidosis. Respiratory acidosis means PCO2 will be high. So, it is metabolic acidosis. Here the bicarbonate is low. So, it is a metabolic acidosis. So far you are clear. Now, you want to see if it is compensated or not. Just remember, as a rule of thumb, if it is a fully compensated condition, pH will be normal. Here pH is not normal. So, whatever compensation has happened, it is a partially compensated metabolic acidosis. Okay, even before calculating your PCO2, you can just tell us it is a partially compensated metabolic acidosis. So, if you want to substitute in the formula and see, this Winter's formula you can use, or the formula that I told you, that change in bicarbonate with respect to the carbon dioxide, that also can be done. So, here we have done the Winter's formula, which is 1.5 times bicarbonate plus 8 plus or minus 2. It is not 20, it is 2. Okay. So, this is not corresponding to the PCO2 here. So, it is a partially compensated metabolic acidosis with normal oxygenation. So, this will be your complete interpretation of the ABG. Always mention oxygenation also. So, we will go to the next scenario. So, look at the pH here. pH is 7.59. Is it acidotic or alkalotic? It is alkalotic. Okay. Look at the PO2. PO2 is 58.7. So, PO2 is less. So, it is hypoxemia. Next, PCO2 is 49. So normally it is 35 to 45. So it is high. Okay. Bicarbonate is 48. Normally 22 to 26. Bicarbonate is high. So we have an alkalosis. Look at the PCO2. Could it be respiratory alkalosis? Not at all. PCO2 is high. So it is not respiratory alkalosis. Look at the bicarbonate. Bicarbonate is high. So it is a metabolic alkalosis. So you have a condition of metabolic alkalosis with, look at the base excess of 21.6. So now next come to the compensation. Okay. So for metabolic alkalosis compensation, we saw for every, this is a metabolic alkalosis. For every 1 bicarbonate rise, 0.6 rise in PCO2 should be there. Okay. So this is a metabolic alkalosis. Lung has to compensate, isn't it? So for bicarbonate rise, there should be rise in PCO2 also. Has it risen correctly? That we have to see. So 24. So for normal bicarbonate is 24. Okay. So from 24 it has gone up to 48. Difference is 24 again. Okay. So for 24 bicarbonate, ideally 0.6 times PCO2 has to be risen. So 24 into 0.6 will come around 14.4. Normal PCO2 is 40. So 40 plus 14.4. Ideally the PCO2 should be 54. But the patient's PCO2 is only 49. Okay. So it is not compensated. So it is a partially compensated metabolic alkalosis with hypoxemia. Okay. So this calculation you can do and you can tell if it is compensated or not. The patient is trying to compensate but the complete compensation has not reached. So for 1 rise in bicarbonate, there should be 0.6 rise in PCO2. So that is the formula that we saw. We have applied that formula and we have come to a conclusion that the compensation has happened but it is not completed. So a partially compensated metabolic alkalosis. Okay. So next we'll move on to the scenario 3. So first look at the pH here. pH is 7.26. Is it acidotic or alkalotic? It is acidosis. Look at PO2. PO2 is so high. Maybe the child is on ventilation and the FiO2 is high. So we'll have to definitely intervene here. So PO2 is high. PCO2. So PCO2 36. 35 to 45 is normal. So PCO2 is normal. Bicarbonate is 17. It is definitely low. Normal is 22 to 26. Bicarbonate is low. Base deficit is there, which is 9.1. Okay. So this is an acidotic condition. Can it be respiratory acidosis? No, it is not respiratory acidosis because PCO2 is normal. It is metabolic acidosis because bicarbonate is low. So you have come to a conclusion that it is metabolic acidosis. Now I want to know, it is a high anion gap. Is it a high anion gap metabolic acidosis or is it a normal anion gap metabolic acidosis? For that I should calculate the anion gap. So anion gap I will calculate because I have the data on sodium, chloride and bicarbonate. So sodium was 131, chloride was 96 and bicarbonate was 17.3. So sodium minus chloride minus bicarbonate. So you have calculated the anion gap. Anion gap is 17.7. So anion gap more than 15 will be a high anion gap metabolic acidosis. Okay, so this is a high anion gap metabolic acidosis. But I will also think, is it a pure high anion gap metabolic acidosis or there is some hidden normal anion gap metabolic acidosis or any alkalosis is present. So some hidden disorder is present or not. For that I will do the delta ratio. So here we have done a delta ratio. So delta anion gap by delta bicarbonate. Delta anion gap is anion gap of the patient minus 12. So anion gap of the patient was 17.7 minus 12 we have done divided by delta bicarbonate. Normal bicarbonate is 24. Patient's bicarbonate was 17.3. So the end result is 0.85. So anything between 0.8 to 2.0 is high anion gap metabolic acidosis. Just go back to the slide where we have talked about the delta ratio. Okay. So this is a pure high anion gap metabolic acidosis. I hope this is clear for all of you. Okay. So we will see another scenario. Next, pH is 7.267. So this is acidosis or alkalosis? This is acidosis. PO2 is 70. It is low. This is a hypoxemic condition. PCO2 is 16. PCO2 is low. So this is not respiratory acidosis. Bicarbonate is 7.4, very, very low. So this is a metabolic acidosis. Look at the base deficit of 17.4. So this is a metabolic acidosis. On any metabolic acidosis, calculate the anion gap. We have sodium chloride bicarbonate. We have calculated the anion gap, which has come around 30. High anion gap metabolic acidosis. So again, do the delta ratio. Delta ratio is delta anion gap by delta bicarbonate. It came around 1.12. So this is a pure high anion gap metabolic acidosis. Okay, clear? So next scenario, again an acidotic pH 7.17. PO2 is low, hypoxemic condition. PCO2 is high. So it is a respiratory acidosis. Bicarbonate is 21. It is also low. Base deficit is 5.5. So there is a acidosis which is contributed both by respiratory acidosis and metabolic acidosis, and there is a hypoxemia. In such situations, what you will expect to do? You will be expected to do which disorder came first. So respiratory or metabolic acidosis, you will find the percentage difference. Okay, so on both from the bicarbonate, from the PCO2, how much percentage difference is there and which came first. So that also we will be able to identify just by the information that we have gotten from the ABG. So coming to another scenario. So pH is 7.28, which is acidosis. PO2 is 30, very, very low, hypoxemic condition. PCO2 is 80, very, very high PCO2. So probably this is a respiratory acidosis. Look at the bicarbonate. Bicarbonate has increased. It is a high bicarbonate. So probably the system is trying to compensate. Metabolic compensation is happening. Base excess is present, that is 8.4. So this is a respiratory acidosis. For respiratory acidosis, we had this 1, 3, 2, 4. You remember that slide? So go back to that slide, and this we will assume it is a chronic respiratory acidosis. Okay, probably a BPD child or a chronic lung disease. So for every 10 rise in PCO2, 3 rise of bicarbonate should be there. So here from 40 it has increased till 80. So 4 times it has increased. So for me 4 times bicarbonate has to rise, which is 12. Ideally bicarbonate is 24. So 24 plus 12, it should be 36. It has not reached 36, isn't it? Bicarbonate is only 34. So it is a partially compensated respiratory acidosis with hypoxemia. Okay. So always make use of the slide where we have talked about compensation. Okay. So we have come to the end of this discussion on ABG interpretation. So whenever you get an ABG, go stepwise. So check for the consistency of the ABG. Yes. Then you have to see, you have to know the normal values, pH, PO2, PCO2, bicarbonate, base excess, base deficit. Normal values you should know. Then stepwise, pH, is it acidotic, alkalotic? Write it down. So normal, low, high. So when you write it down one by one, then by the end of noting all this, so when you have written is acidosis, alkalosis, low, high, then you will come to this, at least respiratory acidosis or respiratory alkalosis. Once you have come to this condition, then you go to assessing if the compensation has done, and the compensation is partial or fully compensated. Make use of that one particular slide, and if you have a hypoalbuminic report, correct the anion gap. That is very important. And for a metabolic acidosis, always do this high anion gap or normal anion gap. If it is a high anion gap metabolic acidosis, do not stop there. Calculate the delta ratio. So all this you will do step by step. It is very easy. Okay. So I hope this presentation is useful for all of you. Thank you so much.